The knee joint's a very easy joint. It's very superficial. I mean, it is, isn't it? I mean, the hip, as you heard Samantha say, it's very hard. You can't feel everything. It's a lot of muscle. The knee is a very prominent bony structure, a few muscles around. Everything's palpable. So I think you can do it in 5 minutes. You can do a lot of things in 5 minutes. I think this is I think we have an easy job. I think it's very difficult. I would hate your job because I have to know a lot, like they do, about that much. You have to know a lot about that, and you know, with the pressures on referrals now that you're going to have, it's a nightmare. So I've always taken the view, if you don't know what to do, refer it and ask a person who knows. That's what I do. So frankly, I don't care what you send me. I never find it insulting, patronising or anything. Please, if you're not sure, send it. So how do you do a 5-minute knee examination? Some things I'm going to say will be repetitive because Panos Thomas covered it, so I'll whiz through some of the stuff I was going to say. But let's start with that. How do I approach it? Well, I'm kind of thinking, is it acute or chronic? And obviously you've filtered that out largely because you've done the referral letter and thought that through. But some people do walk in de novo, particularly in the private sector. So is it acute or chronic? And their age is important because that's going to make my mind think of different diagnoses. The old, it's going to be arthritis, and the young, it's going to be an injury. But they overlap. Was there a specific incident? Again, did they fall? Did they twist? Is it painful? What is their complaint? Are they complaining of a mechanical problem or an inflammatory problem? Have they got pain? Where is the pain? These are all very simple questions. And, you know, can they point to where the pain is? Is it unstable? Is their knee letting them down? Now, that can be due to ligament rupture, as you heard earlier, or it could be due to pain, or it could be due to a loose body. Is it locking up as well? And the latter two imply to be a mechanical problem. So I'm thinking, is it acute? Is it chronic? How old are they? Then I'm asking myself, is it mechanical or inflammatory? So inflammatory problems can present with pain or swelling. So in my history, when I ask a systemic history, and I ask a very quick one, I want to know what drugs they're on, any history of problems, but I'll also ask if they've had psoriasis or got psoriasis. Gout is very easy to forget and miss, and we're all guilty of missing that one. But certainly in the male to ask it. And there's a family history of relevance, particularly in the inflammatory arthritis. So gait, what are we looking at? The first thing, as we heard earlier with people with hip problems, is when they walk in. And actually, it's not just the way they walk, it's the look on their face, isn't it? If they're walking in an agony, you can tell it in their face before they walk in the door. Are they limping? Is it an acute injury? The standing alignment, you can see that as they take their trousers off. It's very important to examine both legs, to compare both sides and look at the standing alignment and the posture of the leg. The colour, is it red, is it hot, is it angry, is it discoloured, and is it swollen? And I think also when I'm examining them, and you heard how the hip can cause knee pain, and that is very common. And it's, again, easy missed. There are plenty of people who have had their knees replaced when they've had an arthritic hip. And it takes 2 seconds to examine the knee and rotate the hip, as you saw there. And if they scream when I'm rotating the hip, that's the hip and not the knee. Why is that? Well, the classical teaching is because they have a common nerve innervation. I think it's simply that they walk with their leg externally rotated, and they often present with lateral knee pain. So we're going to look at them first of all. On your left, that's the valgus knees, those bilateral valgus knees, and on the right, that's a varus deformity. Now, the first thing to say about those is that there is no point sending those people for an MRI scan. You're going to x-ray them, okay? Because they have an obvious clinical deformity. So please x-ray them first. And in fact, probably x-ray most things first when it comes down to it. So the look, the posture, and the way they walk. And they may well have a fixed flexion deformity. Often valgus deformed knees don't have flexion contractures. They're actually quite mobile. And if you've got a valgus osteoarthritic knee, they often keep going for much longer than the varus knees who complain of pain at an earlier stage. So have a routine. Whatever you do, whether you examine the chest, the shoulder, whatever, have a set routine in your mind how you can approach it. So you've asked your history, you've asked where the pain is, then really the examinations to confirm your clinical prejudice and the x-rays and MRI to confirm it further. I start by, having said that, I look at the leg, I look at it in supine position, then I flex it, and I do most of my examination 90 degrees. I'll flex it all the way to compare the range of movement in both knees to see if there's loss of flexion and extension as well. And as I flex it, I'll rotate it to check the hip. And then I'm examining the extensor mechanism. I want to know if they can lift the leg up. You heard earlier how some people rupture their extensor mechanism. It's uncommon, but I've seen that. Examine the joint line and palpate the bony surfaces. And you can feel a lot. That's the tibial tuberosity, osgood-Schlatter's, patellar tendon, pain, and infrapatellar tendon, jumper's knee. So you can feel all that. Come round the side, either side, medial and lateral, feeling the joint line. If it's a meniscal tear, posterior third medial joint line, that's where it hurts. You're going to be right, we'll be right 50% of the time. You'll be right 50% of the time. There are other pathologies that can cause it. You can feel the ligaments, certainly the tender points, the tibial femoral bone surfaces, and the patella. So there's a lot you can feel. A lot of it is very superficial and it's very palpable. And very simply, in most cases, where it hurts is where the problem is. That's it, unless it's the hip and it's referred. And even then, some people will walk in with tenderness in their knee and it's their hip. So you might want to feel the temperature. Obviously, septic joints are rare, and that should be fairly balmed, or in most cases, it'll be red, hot, angry, swollen. They ought to have a fever, temperature, and they'll be in agony. But sometimes that can be subtle as well, and you may pick up an early stage. Is it swollen? The three causes of swelling, essentially. There's fluid, which is the commonest, synovium, then bone, cartilage, hard tissue. Bone tumours, soft tissue tumours, of course, are very rare around the knee. Mostly the commonest cause of swelling will be fluid or synovium. Baker's cyst, at the back of the knee, of course, tends to be posteromedial, and that's all some people complain of. Now, quite often, you rightly will send the patient up for an ultrasound. What you don't do, and what they should do, is aspirate the damn thing. So if you think they've got a Baker's cyst, just say, please do an ultrasound, aspirate and inject. You're not going to do them any harm at all. If the radiologist pulls out pus, they're stupid to inject it. They are doctors after all, sometimes. And if it's yellow fluid, it's synovial effusion. And you've cured the problem, because then otherwise you send them to us, which is fine. Ultrasound, Baker's cyst, please refer. I send them back to the ultrasound and ask them to aspirate it, okay? There's no role for surgery with a Baker's cyst. No need to remove it. It'll recur tomorrow, okay? Don't send it for surgery. Been there, done that, the literature supports it, waste of time. What about fluid at the front? So then if it's swollen generally, there are three grades. There's grade 1, where you've got a little bit of fluid, and you look either side of the joint line, the patellar tendon, and you can flick it from side to side. If there's more, you can block the patella. If it's really tight, you can't do that. So that's grade 3. Then I examine for stability, and I say tenderness. So here we've got a swollen knee, fairly diffuse swelling, probably extra-articular, but could be intra-articular. So the MRI and ultrasound will tell us, so that's blotting it. That's really not showing up, so I'll move on from there. Other swellings, you can have a swelling either side of the joint line. This is lateral. This is unusual because it's medial. A swelling on the lateral joint line is a lateral meniscal cyst until proven otherwise. It's very, very rarely anything else. And a medial swelling, though, is unusual. You can get medial meniscal cyst, but it's unusual. And the whole knee is not necessarily swollen. And the reason you get those is there's a little tear in the meniscus, which may actually not be that visible on MRI, and may be hard to find surgically. So the fluid gets out, distends the capsule, forms a cyst, and it can't get back. It's a one-way valve. And sometimes all they present with is the swelling and sometimes no pain, and obviously MRI will diagnose that. So is the swelling diffuse or is it local? As I said, if there is fluid in the knee, it's only going to be one of three things, isn't it? It's either synovial fluid, it's pus, which should be clinically apparent, or it's blood. So if there's a recent injury, you heard about the Acl rupture, the classic is the knee goes snap, pop, gives way, swells. It swells quickly and a lot because it bleeds. Ligament ruptures, it hemorrhages. Whereas a meniscal injury usually is the swelling takes several hours to develop because it's an inflammatory synovial reaction. So if you aspirate and you see blood after acute injury and it's not, they haven't fractured it, it's an ACL rupture or maybe a peripheral meniscal tear to prone otherwise. Otherwise, synovial. And if you've got an effusion, aspirate it. If you're not happy, worried, send it to us. Or again, I think ultrasound is very useful. We use it a lot. Partly it's quick and lazy and we can just get rid of them and they can stick the steroid in. But it's also useful. They can do it more comfortably for the patient sometimes. And I know you can take issue with that, but that's nice and lazy. Movement, I say, range of movement, full extension, hip, and if in doubt, if the pattern of pain is going down the leg, of course, I'll just stretch the leg. So you can get a lot from the pattern of pain, where it is. Knee pathology does not cause pain up the leg. End of discussion. Does not, okay? It can cause it down to the shin and it may hurt just above the patella. But if they're pointing up the leg, it's not the knee, it's the hip or the back. Stability, you heard some of that earlier. Full range of movement, flexion, 90 degrees, anterior draw test. Does the tibia sag backwards? Posterior sag draw. Collateral tests, I'll show you in a minute, latchments and pivot shifts. I wouldn't expect you to bother with that really. It's hard enough for us to do it sometimes. The anterior draw, that's it, hip flexed about 45 degrees, knees flexed about 90, thumbs, fingers either side of the joint, and try and pull it forward. You can grade that 1, 2, 3. 3 is it comes all the way, and I think if it's more than 2 centimetres, 1's 0.5 to 1, I think. How anyone can measure that, I don't know. I mean, that's just nonsense. Essentially, if it's loose, it'll come forward. If it doesn't move, it's stable. That's the end of it. It's not that accurate. Effusions and meniscal tears that displace will give you a false negative. And just to go back, the posterior is just pushing it back. So if it sags backwards, in fact, at 90 degrees, if that tibia is lying behind the front of the femoral condyle, you can see it sagging backwards. That's a posterior cruciate ligament injury. Thankfully, they're rare, difficult to treat, and they are rare. The latchmans you saw earlier, Panna showed you, do it about 15, 30 degrees of knee flexion. You essentially hold the femur in one hand, the tibia in the other. That is more specific, all right, more sensitive, more specific for a ruptured ACL. So that's doing the Latchman's test, and you'll feel it just pull. And of course, that's what the other knee's for. Feel the other joint. If that doesn't move, that one's loose. Some people have inherent laxity, of course. What do? Do you do an X-ray or an MRI? Well, really, with a significant acute injury, you probably should do an X-ray, because I've seen fractures. I can't, be certain. So if in doubt, I think the patient gets it, and they've had a serious, significant injury. If they just fall and it turns suddenly and it hurts, well, that's a waste of time. But if they've actually fallen, football, skiing, then they ought to have an X-ray first, because there are fractures. And of course, we don't see them because they will go to the A&E. The age of the patient. I think if you're 20, have an MRI. If you're 70, have an X-ray. If they walk in with a deformity like I showed you, do an X-ray. I can't tell you what the cut-off where an X-ray is going to pick up osteoarthritis against, and is of more value than an MRI. But I think anyone over 60 probably ought to have an X-ray. It's going to pick things up more often than not. Certainly anyone under 40, an MRI is my first choice now. And it depends on the complaint, of course, doesn't it? If the knee's grossly deformed, as I say. And then if the X-ray is done, if you do an X-ray in a 60, 70, whatever year old, and it's normal, that's fine. Then do an MRI scan. They should have the benefit of the doubt of the diagnosis. This is something I hate, okay? If this is a report in a 20-year-old, okay. If this would be a report in someone older. So you get the report back, you've sent it to InHealth, those people who prostitute MRI scans, and they they send you a report back by someone from Bulgaria or maybe England that says ruptured anterior cruciate ligament, blah blah blah, moderate degenerative change, conclusion tear median meniscus, ruptured ACL, referred to orthopaedic surgeons. Radiologists should not do that. That's your decision. And we're talking earlier to someone, that's now in black and white. The patient gets that and thinks they should see a doctor. So you've got an 80-year-old granny who's walking around with her arthritic knee that wants to have an ACL reconstruction. And trying to, so they come along and I say, look, the MRI has now shown me that the whole room is falling apart. There is no point replacing the shelf. So... do it. If you are going to do an X-ray, and please, and the radiologists won't do this, radiographers won't do this unless you ask. We know an AP standing X-ray is very valuable, but they just won't do it because it takes time. So you have to put it on the form. Even I have to put it in my own hospital, AP standing every time. A lateral is probably the least useful of all the views we take, but it does occasionally show something. The skyline is the patellofemoral view, and that's very useful. I'll show you that in a second. So I asked for AP standing, lateral and skyline, and occasionally we'll X-ray the hip. I can't emphasise that enough. I've seen too many people have knee replacements who have an arthritic hip, and sometimes they coexist. So the lateral here, you often, if you have done a lateral, just ask for AP lateral, they will say patellofemoral joint arthritic. Well, there are some osteophytes there, but the view we want to see is the skyline to tell us, and that shows lateral compartment wear. So this is a skyline. This shows no space. And I think it's very hard for you guys. You just get the report. You know your patients, I'm sure whether you realise it or not, they think you've seen the scans. They think you've seen the X-rays. And I think it's important, either with the new digital age you see them, or tell them, I haven't seen it, it's just a report. Because sometimes, what Samantha was saying about the report and seeing the films, I've seen hip arthritis refer from the radiologist and the X-ray is normal. So they're wrong. So even the report can be wrong from a good radiologist. MRI is interesting. I think MRI is useful. I wouldn't operate on anyone, probably, without having an MRI of their knee. I want to diagnose this, and I want to know it's wrong. And even locked knees. So classic was the locked knee. You come in with a locked knee, you need an arthroscopy. We were wrong. MRI shows us we're wrong about half the time. There are other causes. It can be an acute ACL injury. It can be bone edema. So there are other reasons. And these were knees where orthopaedic surgeons assessed them and said they're locked, they need surgery. Let's see what the MRI shows. So it's not always a meniscal tear. The ACL we've mentioned, just to go back, just to remind you, that's the middle of the knee. There's the anterior cruciate ligament, posterior behind. Menisci, two semicircular structures. There is the lateral, and there's the medial, which is bigger. They're mobile. As Pano said, the blood supply just comes right, I would say actually just at the edge, just 5–10%. So most of them are avascular, which is why if they tear, they don't heal. As we age, so I'm sure your knee as a young man is fine, and your menisci are rubbery and elastic because they have large water content. As we age, we get wrinkles and we lose our elasticity because the collagen doesn't keep the water in, and these things are the same. So they become more brittle. So 40 plus, 30 plus, certainly 50, they're more degenerate, simple twist, you can tear your meniscus getting out of a chair. So the concept you have to play sport is not true, but a 20-year-old will have to really twist it. So very quickly, low-speed injuries, mostly will produce a twist, a simple twist or a fall. Football will rupture the medial ligament or the ACL or the meniscus, and high speed will cause further problems. I'm going to skip over that. Just go back. I just want to make, if you've got an ACL rupture and that you've got an MRI report of that, if there's no meniscal tear, no loose body, and it's acute injury, physiotherapy, get it straight. If they haven't, because they'll often present with lack of extension, haven't achieved extension after 3 or 4 weeks from the injury, they need surgery to remove the ACL remnant and a later reconstruction. We don't do it at the same time because they will end up with a stiff knee. If the MRI shows an ACL rupture and a bucket-headed tear of the meniscus, that's fine, surgery. But if there's no associated pathology, it's physio first. If they don't get it straight, then it's an arthroscopy. If they get it straight, then it depends on them, doesn't it? It depends on if their knee's letting them down all the time, as Panos said, or if they're a keen sportsman. If you've ruptured your ACL and you want to play football, you need a reconstruction. End of discussion. It's not going to work otherwise. So it doesn't matter whether you're a professional or an amateur. So that's a lifestyle operation. And very quickly, this just shows some of the mechanism that can happen. So you twist the knee, femur's essentially fixed, semi-flexed knee, ruptures it. You can rupture the medial ligament, it keeps on going, ruptures it more, ruptures the ACL, and then it can do the meniscus. And then the final thing that happens is This may, of course, not rupture, just the ACL, but the lateral side, the femur and the tibia impact. And on the MRI scan, the acute injury, we get a report saying there's bone bruising there. And that's almost pathognomonic of a ruptured ACL, acute one, not the chronic. I'm going to skip on that. So I mentioned earlier about that old lady with the MRI. So meniscal tear does not mean arthroscopy every time. In fact, it depends on the symptoms. If I've torn my medial meniscus, which is the commonest, of course, if it doesn't hurt very much, if it doesn't give way or lock, nobody's operating on it. And I don't care what the MRI shows. So it's the symptoms. And what I'll say to a lot of people is, if they haven't got mechanical problems, come back, particularly the older person, 40 plus, whatever, come back when it causes problem. When you've had enough of it, that's the time to refer. So those reports are saying meniscal tear, please see orthopaedic surgeon. That's up to you. That's your discretion, and they should not write that. So I'll skip on that and that. This is bone bruising, just to show you. You sometimes get MRI reports. This is a sagittal section. There's a femur, tibia. This is lateral. That white signal we see is bone bruising. That can be due to injury. It can be spontaneous. Sometimes means there's underlying avascular necrosis. And that's not an uncommon diagnosis. So they appear to have a meniscal tear and they've got a bone bruise. No surgery, rest, rest, rest. Some of the footballers they give biphosphonates to, but I mean that has its own potential risks, so I wouldn't do that. Lastly, a few comments on the osteoarthritis of the knee. If you're a 25-year-old male, now in America, this is their data, the risk of you getting osteoarthritis of the knee by the age of 60 is 8.5%, and in a woman it's 10%, so over 10. So higher in women than men, and that's 1 in 10 of the population. The risk of the same group having to have a knee replacement is obviously less, but it's still high. So that's 4 out of every 100 women who are 25 now will have a knee replacement after the age of 60. That's quite a considerable statistic to think about. There's the national joint registries now in the UK. They've been around in Sweden and Australia for some time. And we can now track data from that. And you can see now how the database is getting better, so we're picking up more. But something like 80,000, 90,000 hip and knee replacements are performed in England and UK every year. So as many knee replacements are performed as hips, and the number of knees will rise disproportionately to the number of hips. What do you do for an arthritic knee? First of all, nothing. If it doesn't hurt, don't do anything. The reason you operate, the reason we do anything is pain. If there isn't any pain, leave it alone. Just reassure them it's a bit sore, tough luck. Physiotherapy, I think, can help a bit. If they've got a deformed knee, if it's in marked varus, it's a fixed contracture, it's a waste of time. And the guys here, physios may disagree, but I think it's a waste of time. If they've got good movement, they can teach them some quadriceps exercises. Anti-inflammatories, of course, that's going to be your main treatment, and ours as well. I think they should have a trial. Injections, you can put a steroid in the knee, you can put Synvisc or whatever you want to put in there. They work about 50-60% of the time. And I think that's fine. It's easy to palpate the joint line, stick it in. If you're not sure, get them to do it with an ultrasound. Arthroscopy, I mentioned in a minute. Tibial osteotomy, occasionally we operate and break the tibia to realign the knee. I think if you can avoid that nowadays, I'd try and keep it until they need a knee replacement. The best operation is the last one and the only one, which is a knee replacement. I think you spoke about knees this morning, so I'll whiz about that. We can talk about that if you want. Those are the options. The commonest operation is still a total knee replacement. You can replace the patellofemoral joint. The Australian registry results are dreadful, something like a 30-40% failure rate of 3 or 4 years. The commonest arthritis I see is patellofemoral wear of all ages, and most people don't need anything. What they actually complain of, it hurts to get out of a chair or get on the bus. Tough, okay? So just carry on. And revision. Arthroscopy, again, that's something, I think the message is out there to most people now. For osteoarthritis of the knee, it's a waste of time. It doesn't do anything. If they've got a loose body, fine, or a meniscal tear in the normal compartment, maybe. but actually just washing out the knee, and whoever thought of it, the idea we pour some fluid in and wash it out, was a genius, because it made some people a fortune. This was done years ago. A lot of orthopaedic surgeons were very critical of this paper because it affected their income, but it's a good paper. This was from America. The criticism of the paper was that it was done in a veterans hospital, which is where the ex-military go. The second thing, that the patients were all male. And the third thing, that they were all below the rank of officer, so they were thick because they were male, and they were inscripted, but there you are. So they took 180 patients, they split into 3 groups. One lot they washed out. Amazingly, they got consent, they put them to sleep. One group, they just lavaged. The other, they washed out and debrided the rubbish. And the other, they just put the arthroscope in and had a coffee and then came back. and it's amazing they did that, isn't it? And there was no difference, absolutely none. So it's a waste of time, okay? So you get people... And the worst is you can make people worse. I had a lady who was a GP, and she'd had her knee washed out and it got infected. And she needed knee replacement. So now we have a problem. So we don't do it. Occasionally in the younger person you might. Actually we're treating ourselves because we don't know what else to do with them, but it's a waste of time. So you can get infections very rarely, but more commonly you can get bone edema after arthroscopy. And you'll see that. We've operated on some, they're coming back still bitching about their knee, and it hurts. So arthroscopy is not a benign procedure, and I do warn people more now because I've got some people that hate me because of that. So beware. Just to go back, one other thing. There was a practice that used to happen, particularly in normal knees. Surgeons would do an arthroscopy, anterior knee pain, typically in a young person, a woman, and then put a steroid in. That is bad, okay? There's no logic for that. We shouldn't put steroids into normal knees, and there is some evidence if you put a steroid into a knee after an arthroscopy or during it, the infection rate is higher. So we don't do that. So you shouldn't do that. So I said earlier, the problem with osteoarthritis, I think these are interesting figures. The population's getting older, their expectations, projected 200% increase of osteoarthritis of the knee. We're going to be busy. She's not going to be that busy. The hips aren't going up that much. Okay, so the knees are bad. And infection is a problem. In the US now, they think it's almost 2% over 10 years, 1.5% in the first 2 years, and the rest in that. So we've got another problem, which is dealing with the complications, but the number is set to escalate. Why is that? Well, first of all, people are living longer. The top line is Western Europe, and the bottom line is Africa and Asia in between. Total knee replacement, say this is old data from the US, but the line's still going up. The knee replacement, demand for knee replacement is going that way, and the hips are plateauing. And the yearly incidence, this is from the Swedish registry, very simple, is going up, but also, and females more than men. And why is that? Well, one reason is obesity, that's for sure. There is a link between the two. That's a fat map of England, and so they know where you live now. But there's also an increase in the middle ages. So very quickly, the sort of middle age range group is increasing. The 45 to 64-year-olds are growing disproportionately as well. That number's tripling. So we're seeing the old, we're seeing the obese, I say more in women than men, and no one knows why. It's not just the obesity. There's also demography. If you're from the Middle East, you don't get arthritis in the hip. There's always one or two, but it's almost unheard of. Whereas osteoarthritis in the knee is very common. So if you take the whole populations of the world, knees are more common, arthritic knees more than hips. And as I say, we're seeing an increase in this group. Why? Oh, that's just the cost. And so it's a big problem for our economy. Why increasing in the younger patient? Well, sports injuries, people are doing more sports, of course. We produce lots of arthritic knees by taking out menisci, filling with the ACL, etc. So we're creating a whole group of patients. Our attitude has altered because the knees are doing better. There are complications, I'm sure you heard this morning, but they are lasting longer, and the new joints are very good, and they're getting better and better. We're better at doing it. So our threshold for doing a joint replacement, I wouldn't deny a 40-year-old who can't walk. It's absurd. What do you say? Come back when you're 60? Do it now. And of course, there's this direct consumer advertising. This is a reputable company in the States. They sell this knee as the all-terrain knee. This is utter rubbish. This is nothing. The weak link, the plastic wears out. I would advise you, fine, you can walk with it, maybe even ski, cycle, but no impact sports. So there is no such thing as an all-terrain knee, but the patients believe there is, so they'll fall into it. If you were born in 1961, you had a 13% chance of living to 100. If you're born now, 30% of people who are born now are going to be live when they're 100. And as I said to you, 4% of those women are going to have a knee replacement after the age of 60. That's a massive number. Okay, we can't afford it. This is from the work and pensions data, and this is change in demography. Okay, so here we have males, females, start in 2000. I'll run it again. It will start again, and this is why they're worried, isn't it? Because this is the paying population. They're getting older. That's 2005. That's a nice balance. We can afford the health economy. And in 2050, we're going to be struggling. And that's probably wrong that way because it's going to go up. So the numbers of the population is getting older, and we're not going to be able to afford it. Very brief, horrible slide really, but 3 things here. Under 55, over 65. If you have a knee replacement, this is from Sweden, this is a little old now, and it's hips as well, knee replacement, different types. Essentially, the failure rate in the younger group is significantly greater than in the older group for all knees. So the top one is a total knee replacement. These are unicondylar and things, but so that's what, 98% lasting 5 years, and then that line pretty much plateaus until about 12, 15, whatever. This one is 92% to 5 years. So if you're under 55, the chance of the knee replacement failing within 5 years is 5, 8%. Over, it's 2, 3%. So a problem for the young there that we see. So the young are living longer, the old are living younger, all right? You've got 70-year-olds skiing and doing whatever, playing football, and they all want to be fit and young. The costs are increasing. And I think we've kind of dealt with that really. 70-year-old female, swollen painful knee, several weeks, has an MRI. Do an X-ray first, please, because she'll get a report saying she needs an ACL reconstruction, and you can treat that yourself. The younger one is different. Get the MRI, and maybe we can talk about that. So when to refer? I think if you need advice, fine. Now with digital X-rays, some of our local GPs write a letter and say, well, you can phone, I don't mind, can you look at the X-ray and tell me what to do? That's fine. I don't care about these nonsense of commissioning things. If you want some help, you should be able to ask. I mean, if you get hundreds, it's a problem. But, you know, if you're in doubt, fine, and if you want certainty. And questions, there are no stupid questions. There are only stupid answers, okay? Thank you. Thanks, Chris.
That's great. Well, thank you very much. Epitomising the 3 Ps for presentation. Practical, pragmatic, and politically incorrect. Thank you.
Thank you, Dustin.
So thank you very much. So questions on knees, please, or anything related to the presentation? Yeah. We've got a mic, please.
We can examine the knee if you want, but see.
Okay.
Two quick points. The first one you said about if it's a ACL rupture with no other pathology, just physio. Unfortunately, like yourself, I've seen lots of MRI reports which have been inaccurate.
Yes.
And so it's difficult now to say, well, actually, just as ACL ruptured, nothing else, because I've seen people who have meniscal tears with a normal report and something wrong on the MRI. So it's difficult there. And the second thing is, you say just write to you for advice or just phone. It's got a bit crazy where I work because now you have to ask advice through Choose and Book, and it costs us.
You can write. You can still write a letter. No. If you write to me, I mean, just the local, but I mean, not hundreds. I mean, Yeah, someone wrote the other day, and I just looked at the X-ray and wrote back. I think that's fine. You know, I don't care about the cost. I mean, it's a letter, for God's sake. The other thing about MRI, you can, of course, have a meniscal tear with a normal MRI. And one of my slides didn't dwell on, showed the movement of the knee. So we do operate on people who have normal MRIs. They fail physio, they fail tablets. So the undisplaced meniscal tear won't show. And sometimes the MRI, they can't be certain. The ACL, you can see something as well. Again, if in doubt.
But sometimes the actual reports are very different to the actual images.
Yeah, totally.
That's the problem.
I don't trust the report. I think it's very difficult for you. I wouldn't expect most of you to be able to read an MRI of the knee. I look at the backs now. I don't do it very often. And I can't. So I leave it to some nose. But that's our job. Yeah.
Okay. What Howard was actually...
Yes.
I was just going to say, what Howard did you say to me as I came up is that he's happy to do a presentation on examination. I think if it's okay, we'll go ahead with that. Be great.
All right, Carl has kindly volunteered. Carl, I hope is fit and well anyway. So should we stand you up, Carl, just to make a point, and we'll spare your modesty by just hitching that up a little bit. So first of all, the standing alignment, as I say, just look as they walk, and this doesn't take a minute. You can see that as they take off their trousers, or dress or whatever, it's very difficult now. If you have a young woman, you've got to have someone in with you as well. So that's, you know, you're all right, I think. So standing, looking, alignment, and is it deformed? And, you know, are they standing like that? Is it contracted? And let's lie down. Thank you, sir. And I think, as Samantha said, the patient should lie flat. Unfortunately, there's no pillow here, Carl, so you'll have to put your head through that. And then, you know, I look at the knee. If that knee's in, let's say they're lying like that with the external rotated, that rings alarm bells to me. Is it the hip joint, okay? And certainly that's because sometimes they're lying like that because their knee is actually contracted, so they've got a flexion contracture, either it's locked or osteoarthritis, so they can't straighten it, so they lie out. But if the knee is straight and they're lying out, I just wonder about the hip straight away. And if they're complaining of pain and they say, it hurts me up here, it's the hip, you know. Does it hurt to put your shoes and socks on, cut your toenails? Very old-fashioned questions, very relevant. That's the hip, not the knee. So I look and see if it's swollen. You can see either side of the patella, and there's a natural concavity. If that's gone, there's fluid there. It could be something else, but it's likely to be fluid. And you can flick it from one side to the other to see if you get a ripple effect. If there's fluid in the knee, if they've got an effusion, something's irritating the joint internally. It could be a meniscal tear or degenerative change. There aren't many things it could be, really. If it's very swollen, very acutely swollen, very tense, and there's no injury, you might worry about an inflammatory problem more than anything else, although occasionally you can see that with a meniscal tear. Then, can you lift the leg up straight? Two things, you can tell that he's got full extension, and secondly, he's got an active quadriceps mechanism. That has to be intact. I saw a patient treated at a good teaching hospital. After several months, he came, he said, my knee's locked. I said, why don't they do an arthroscopy? He said, I don't know, they keep seeing him in there. You need an arthroscopy. So I asked him to lift his leg up, and he could just do that. He couldn't lift it. He'd ruptured his extensor mechanism, and nobody had examined him. He'd just been passed from one to the other. So that was bad news. Then flexion and bend your knee. I always put my hand on the front of the knee, out of habit now, because you can often feel, sometimes hear, patellofemoral crepitation. If someone's got a noise in it, it clunks and it doesn't hurt, tough. They don't need to do anything. So having flexed it, as I do that, I also rotate the hip. And if it hurts doing that, it makes me wonder about their hip. Then I sit on the foot, tibial tuberosity, palpate it, patella tendon, is it tender? Infra patella tendon, is it tender? Jumper's knee. Either side of the joint line, you can feel it. You fall into a natural concavity there, and that's the lateral joint line, and then the medial coming round. And if they've got a medial meniscal tear, it's usually the posterior third. If they're tender anteriorly, I worry about a chondral defect, so they've got some osteoarthritis. Then the anterior draw, the knee's flexed, I'm sitting on the foot, the hip is fixed about 90 degrees, put my thumbs either side of the tibial tuberosity and just pull it forward. And he's got some natural give there, that's normal. You can grade it, as I say, frankly, if it comes like that and there's no hard endpoint, it's loose. If there's a slight jog and it's the same, it's irrelevant. The Latches Test, I often put my knee under theirs just to support it. I put my hand behind the knee, thumb at the front, and then pull the tibia forward. And the collateral test, I tend to hold it either side and just push one to stretch the medial and out the lateral. And don't forget the Baker's cyst at the back. And that's essentially it, really. That's 2 minutes, isn't it? Okay. Thank you, Carl. Very good.
Thanks, Carl. Okay, fine.